Good morning, Dr. April Salama. How are you?
I'm doing well, thanks. How are you?
Well, thanks again for taking the time to join us on this Beating Melanoma project. And we are super thrilled to have you as a part of the esteemed colleague and a member for the interview. So I'm just going to quickly introduce you. So you are Dr. April Salama is a associate professor at the Department of Medicine at Duke Health, and you see patients mainly focused on melanoma as well as other type of skin cancer. In addition to seeing patients, you also conduct clinical trials. You received almost 30 or so grants, published 100 numerous scientific articles. And most importantly, I think for our audience, you recently served as the one of the member for the National Comprehensive Cancer Network, the NCCN guideline for creating the melanoma guidelines, which was published in 2022 last year. So with that, welcome again.
Thank you. Thanks for having me.
I'm going to call you April. Please call me Steve. Let's be casual about this whole thing. So let's first start out. Can you tell us what this NCCN panel, what it is about, and what is it like sitting in the room with all those 30 or so experts around the world and try to figure out the guidelines for treating melanomas?
Yeah, so the NCCN is a wonderful organization, a nonprofit organization, which disseminates evidence-based guidelines, and both online primarily now, but they host a series of conferences and symposia, and it's really about bringing together key opinion leaders and experts in the field from multiple different disciplines. So, of course, on the melanoma panel, it's, a privilege. I'm a medical oncologist, but we have dermatologists, surgeons, radiation oncologists, really all of the, expertise that would be involved in caring for a patient, with this disease, and in this case, melanoma. And we really aim to sort of synthesize the data and make recommendations that are available for review for other physicians, for learners, that are really evidence-based.
So how long was that process to, gather everyone? And do you guys meet virtually, or do you actually gather in one setting? Or how long did it take for you to review? I mean, there's a lot of data out there.
Yeah, it's a combination. Of course, COVID, has affected things, but we do still meet in person from time to time. Mm-hmm.
And so those guidelines are recommendations, or are they just sort of how does that work? What do most medical oncologists, or what do physicians, surgeons, how do they use this information?
The feedback that I receive from our partners in the community, in general has been very positive. I think people do use it as a reference and a guide. I think, obviously nothing replaces, clinical decision making and, best medical judgment, but they're there to serve as a roadmap, for practitioners. For example, someone who maybe doesn't just see melanoma, that may see many different types of patients with different cancers, and that may want kind of an update and guidelines. I think it's, can be an excellent resource.
All right. I'm glad we sort of clarified that a little bit, because I think it's a great resource for anyone for physicians and for the patients to understand, what is the current state, what are the guidelines for treating melanomas. Why don't we step back? And I mean, obviously, you are one of the world expert and medical oncologists in dealing with advanced stage melanomas, and not every patient will have access to you. What is it like when a patient come to your office to talk about, treatment? And let's start with a patient that has, let's say, stage 4 disease. How would you walk them through that process?
Yeah. Well, first of all, it's a, privilege, obviously, to be able to care for patients. And we recognize we're meeting them at a really difficult time. No one really wants to be in my office, even if we're nice and we'll have a wonderful team and a wonderful staff and great resources here. We recognize that this is usually the last place anyone wants to be. With melanoma, many of our patients had a previous diagnosis
Sure.
of melanoma, so it's something that maybe has been on their mind or something that they've been worried about. But it's always really scary to get that news. And I think I really just reflect back on how much my practice has changed, over the past 10 plus years that I've been practicing, just with the advances now, that I think it's important to convey that even though it's a scary time, there is that hope because of the therapies that we have. But we start just like any other, office. We get to know the patient, we review their records, we learn a little, bit about them, how they've been feeling, and all of those things, we kind of start to piece together a treatment plan for them.
So when you piece together a treatment plan, and usually patient perhaps walk into your office already have some imaging, so let's start that process. So let's say you got the imaging work, you notice, you saw this is proven stage 4 disease, and what is the first line of treatment? How do you make this decision between, let's say, immunotherapy versus targeted therapy, let's say?
Yeah, that's a great question. And it's one that we've sort of debated now for years. But we actually have some nice clarity,
Sure.
thanks to some nice data that has come out. And of course, for our audience, you're, referring to that we know that, approximately half of patients with melanoma, their tumors have an activating mutation in BRAF. And we're fortunate to have very good therapies that can really effectively target that gene and have demonstrated benefit for those patients. On the other hand, we also have great advances in immunotherapies. I kind of collectively call them checkpoint inhibitors, and we have a few different flavors of those. But we were really, for a while kind of debating, let's say you come in, we have your scans, we know that we have a biopsy that's showing melanoma, and maybe we even have the molecular genetic testing back that shows that there's a BRAF mutation. We weren't so sure which therapy, would be best to start with. And I think we now have pretty, convincing data from the DREAMseq trial that sequenced targeted therapy followed by immune therapy with checkpoint inhibitors with IPI and Nivo. I'll just use the short names we use.
Yeah, definitely.
Followed by the reverse order. And it showed that the patients who started with IPI Nivo did better, that more of them were alive at 2 years compared to patients that got the reverse order. And so we really, kind of underscores our feeling that, first line therapy for most patients, and it's not all, but most patients, really should be immune therapy based, in my opinion. Which immune therapy.
Well, we're gonna get into that. We're gonna
Which
get
combination,
into that.
yeah, that's the different conversation. But I think, for most folks, immune therapy really represents the possibility of durable control.
So again, I think for our audience out there, this is a discussion, and for specifics, you really have to basically sort of go see your own doctor, your own medical oncologist, just because they're the one who really knows your specific conditions really well to figure out. Again, your point is absolutely right on. That is, for most patients, immunotherapy seems to be the first line. And why don't we sort of flesh that out a little bit? Monotherapy or dual therapy, and now we have this LAG-3, and how do you choose? And what is your decision-making process, basically?
Yeah. And again, this is another area where it's a lot of opinions and a lot of really individualized, sort of decision making between the patient and their oncologist, because we really don't have head-to-head trials, comparing what you just, basically refer to, these 3 regimens of just a single agent PD-1 inhibitor Then we had Ipi and Nivo.
Sure.
So, and then the newest, sort of combination on the block is the LAG-3 with Nivo-Rela. My view is that we don't have a perfect therapy. There is no perfect therapy. So it really is about weighing risk and benefits. I do think most patients, again, not all, but most should probably get a combination immune therapy. That's sort of our bias at Duke. In general, we typically see response rates that are numerically higher. And we have a trial, of course, comparing Nivo-Rela versus Nivo, where the combination was superior, at least in terms of progression-free survival. But the flip side of that coin is the toxicity. So with Ipi-Nivo, we see a pretty big jump in some of these potentially serious what we call immune-mediated adverse events, but basically, the side effects that we get from the immune system sort of turning on the patient's own body. And some of these can be very serious. So a little bit of it depends on a, kind of patient tolerance for risk, how healthy they might be, other medical problems they might have. A little bit of it too, more than a little bit depends on, the extent of their disease,
Sure.
and how we kind of balance that risk and benefit.
Yeah, I think this is a really not an easy decision to make, right? And you talked about a number of different determining factors, such as extent of the disease, the patient's own health, other comorbidities, right? And also the risk tolerance. And obviously, we sort of touched upon this because monotherapy, when you talked about, so one of the questions maybe that your patient is asking you is, you talked about progression-free survival seems to be a little bit better with the dual therapy. But what about overall survival? Does the data show that dual therapy is better?
Yeah, it's tricky because of the way some of these trials were designed. And there's statistical significance, and then there's clinical significance and parameters in the real world, kind of day-to-day practice. And I think it's to be fair, there was not a statistical difference, even though there was a trend towards improvement with Nivo-Rela versus Nivo. We of course have a trial looking at Ipi-Nivo, Nivo, and Ipi. And that trial, the way it was designed, it was really comparing the PD-1 based regimens to Ipi, which was the standard at the time. And that's not something we use a lot, by itself anymore. We really use it with, the PD-1s. But numerically, we have really long-term follow-up data, from these trials. And we know that for sure that patients with a PD-1 based regimen do better than patients who get Ipi by itself, which is why those therapies sort of jumped ahead of
Sure.
Ipi, even though that was the first checkpoint inhibitor to bear. And we do see numerically higher response rates with combination therapy. We do see numerically, higher numbers of patients who are alive. But at the same time, there are just questions about how we sequence these therapies. Like, for example, could you treat someone with PD-1 monotherapy, and if they respond, wonderful, but if they don't respond, maybe then they could get, Ipi-Nivo if they're worried about side effects. So we certainly realize we're over treating, probably some patients to try and, capture the benefit for as many patients as possible. But, because we don't have a biomarker, to select these patients, it's largely a clinical, judgment and a detailed discussion with each patient.
What is that process? Like, how does it, by the time you finish the discussion, right, and you share the pros and cons, everything, a lot of patients probably will feel overwhelmed at that point. Yeah. Do they just turn to you and say, "Doc, what should I do?" Is that usually how this conversation ends?
It depends. I think patients come to us at different points in their journey. I think a lot of patients do come to us for a recommendation, and I think that's an important part of every conversation that I have with a patient. So I never, you know, put things out there and just say, let's just choose. It's not multiple choice. But I really view the consultation as a chance to get to know the patient, a chance to see the kind of questions they're asking, a chance to a little bit to learn more about their goals of their care. And then when I have that information, I can usually help them, between the various
Yeah,
flavors,
yeah.
if you will. I can usually help them, kind of make a decision about the therapy that's going to be the right fit for them. Or if, they're not sure, I'll make a recommendation and I'll tell them why. For example, if I'm hearing someone, they're asking a lot about side effects, they're really worried about making trips back and forth and getting to the hospital. Maybe they're older, maybe they, have other things going on. I tell them that I hear you saying this, that if you were to get a side effect, or that, this would really impact things. And, so because of this, maybe we should take a therapy that maybe not as many people respond to, but also is a lot better tolerated. And I make sure that really they hear that, and that sort of sits well with their value system. And sometimes people say, no, that's not what I mean, so I
Yep, yep,
really
yep.
think that informed decision is just so key.
No, I think you're so right about this process, right? I mean, I think one of the most important element about getting good prognosis, getting good care is that patient-physician relationship, right? And then I think, medicine is not kind of an algorithm. You just you have XYZ, you choose this, you choose that purely based on number. It's what you're doing is so great because you're trying to basically figure out that person, figure out the individual needs, both the medically and socially, right? And that makes a huge decision. Shifting gears a little bit, let's talk about side effects. And we know some of those autoimmune mediated side effects. The most feared one is pneumonitis and also perforated colon type of things. And you got also other sort of autoimmune like diabetes, etc., and endocrine mediated issues. How do you monitor those patients, and what do you tell them so that you can avoid some catastrophic side effects?
Yeah. So I'm glad we're talking about this, because it's just such an important point. Because the challenge here is, we got so used to in oncology managing side effects by just stopping the drugs. And that's how we manage side effects for every other drug, basically up until immune therapy.
Sure.
And the challenge is that these side effects often require specific management. So stopping the immune therapy is usually not enough. And we really have to educate our patients, that we really need to know as soon as, something happens or seems out of sorts. My patients will tell you, I'm often quoted, patients know their bodies better than doctors and better than scans. And so we need to know when something is not right. We also try to check in on these patients, we have great nursing staff and support who proactively, also check in with folks as they're able to, because really the key is
How are
prompt.
you doing this? You're just doing remotely, like via telephone
We
call?
are. Telehealth has enabled,
Sure.
not that it's not ideal in every circumstance, but it is a little bit of a silver lining that sometimes we're able to, touch base in between visits with patients. Yeah.
What are you telling your patient to look out for? I mean, I heard various other medical oncologists and they share some of their insight, but what are you telling your patients to pay particular attention to?
When we look at the data, I think the most common, skin and other things are the most common. I
Sure.
tell people that's usually not dangerous, although rarely it can be, but it's usually just annoying. But things like the GI toxicity, in particular the colitis and
Sure.
diarrhea, you mentioned pneumonitis, I would say are, particularly the GI related toxicities are by far and away kind of what drive a lot of the morbidity, when you look at some of our clinical trial data. So we really talk about, abdominal pain, cramping, changes in bowel habits, really anything that is, sort of out of sorts, because as you said, some of the endocrine things can be pretty insidious and just present as fatigue, but can be dangerous, if adrenal insufficiency goes undetected. So it's a pretty high, level of vigilance, especially when someone's just starting off on therapy, because that's often where we see, especially some of the severe side effects come on is kind of early on in the course of therapy. Patients we have little cards, the drugs that they're on, because they may not come to us necessarily. This may happen at urgent care on a weekend, or we may not hear about it right away. So we just want to have a way, that education for other physicians, I think, is key.
What's on that card? Because that's such a good, useful tool, right? I don't see that. I mean, I think this is something that all the patient on those immune therapy should have. Like, what do you put on those cards? Just say, I'm on this drug?
Yep, it talks about the drug, and then it talks about a little bit about immune, mediated adverse events, that diarrhea from immune therapy is different than diarrhea from chemo, things of that nature. And importantly, our contact information. So a patient at Duke, it's our patient, and we're always on call.
No, this is just a great life-saving advice just right off the bat, right? Because I don't think I haven't heard too many other physicians are giving people this card, right? And I'm sure there's other ways to doing it, but this is such a great, useful information. All right, let's move on to a little bit more controversial issues. And let's talk about stage 3. What do you do in the adjuvant setting? Meaning that, and how do you use, oh, wait, before we even get there. So we talked about your first line in most cases is immunotherapy, and then let's say if immunotherapy doesn't work, do you fall back onto targeted therapy, or you're looking at clinical trials or looking at something else?
Yeah, I mean, I think I'm biased, right? I do clinical trials for a living. So we always think a clinical trial is a good option. But, depending on the specific situation, I think, targeted therapies certainly are effective, in the second line. And that in some cases may represent the best choice for a patient.
Got it. All right, let's go down one level to stage 3 in adjuvant. And maybe you can describe for our audience, who's watching this for the first time, what is adjuvant treatment, and what does that mean?
Yep. Yeah. In my clinic, I describe it as additional therapy after surgery to try and minimize the risk of your cancer coming back.
Okay.
So that's the simplest term.
Why? So let's say someone has stage 3 disease at that point, they have nodal disease, and what do you do at this point? They come to see you.
Yep. As you know, stage 3 is a wide range of patients and a wide range of risk. And certainly it ranges all the way from some of the lowest risk, stage 3A patients, certainly in the new HACC, who actually have a quite a favorable prognosis despite having a positive node.
Yeah.
All the way to very, very high risk patients who have a very high rate of recurrence and developing stage 4 disease. My feeling of this controversy, and you're right, different docs feel differently. I would say I tend to offer and recommend adjuvant therapy for certainly the higher risk stage 3s. And I just think there's a value in not having to tell or being able to delay telling a patient they have stage 4 disease, because we can do a lot in the stage 4 setting, but there are a lot of patients who we can't help. They're, patients with brain metastases and other things that are sometimes very resistant to treatment. So I think there's a lot of value in preventing or delaying recurrence. I do think it is the same discussion about risk and benefits, except it's a bit different when you're in this preventative setting. And again, I think you have to understand that. That's not to say that all of my patients get adjuvant therapy, but I think it is certainly worth a discussion for these folks.
So I guess the data is still in question at this point to sort of see whether the adjuvant can improve overall survival. I mean, I know it shows better improved progression-free survival, and
Yep. So I think it's a great point because historically overall survival has really always been the gold standard, and that's
sure.
what we equate with cure. But I'll be, to be realistic, because our therapies are quite good in the stage 4 setting. I'm not sure that we're going to see an overall survival benefit in our adjuvant trials. I think that may be a really high bar to prove. But I certainly think there's been sort of a consistent benefit, demonstrated in terms of improvement in relapse-free survival. So I certainly think it's worth consideration for a lot of patients with those higher risk. And so I'm really referring to stage 3B
Yeah, yeah,
and above.
yeah, that's what I was going to actually, thank you for mentioning that, because I was going to try to get that clarification. You're absolutely right. 3A somehow, strangely enough, have actually improved better prognosis than some of the stage 2 patients. What about, in your institution, are people doing neoadjuvant treatment? Meaning you give, let's say, 2 doses of PD-1 and then going to do surgery in some of those patients, or?
Yeah, I think this is one of the most kind of exciting, kind of hot off the press areas where the practice is really kind of changing in real time. And this is in large part to Sapna Patel, Dr. Patel, who led a SWOG neoadjuvant study that was randomized. Now, we've had a number of single-arm neoadjuvant studies that have shown a lot of promise, and importantly, prognostic factors based on the degree of response in the lymph node. So you get, and just to sort of clarify, right, neoadjuvant just means you're getting.
Yeah, why don't we explain to people what neoadjuvant means, and before we got into this.
So you're getting a drug therapy. We kind of talked about the adjuvant piece, the drug therapy piece, but instead of getting it after surgery, you're getting some component of it before the surgery. So it gives us sort of a real-time look into how effective or not the therapy is, because with an adjuvant trial, the cancer, all the cancer we can see has been completely removed.
Sure.
And so if your cancer doesn't come back, to be fair, we're not sure, was your cancer just cured with surgery alone, which a good number of patients are, or did the adjuvant therapy help you in some way? And there's really no way to tell for any individual patient. But for neoadjuvant therapy, we get kind of that early biomarker that when the surgeon takes out a lymph node, and I should say this is a certain group of stage 3 patients. These are.
Why don't we clarify that? What stage 3 are we talking about? And
Yeah.
I should have asked that question in that fashion, but go ahead.
Yeah. So, many of our stage 3 patients are stage 3 because they were diagnosed with a melanoma on the skin that was a certain depth. The surgeon did the sentinel lymph node procedure, and that came back as showing microscopic amounts of tumor in a lymph node. And I would say that's a big proportion, and probably how most stage 3 patients are identified. But a certain number of patients present with a node that we can already feel or someone can already see on a scan, and we call that macroscopic disease. And that's the group where we're really talking about neoadjuvant. So neoadjuvant doesn't apply to the sentinel node positive patients, because there's no way to know if they have positive disease in the node until the time of surgery and pathology. So the neoadjuvant patients can get some therapy ahead of time, so before surgery. And when the surgeon takes out the lymph node, the pathologist can look at it under the microscope and tell, with now pretty good data, about the degree of effect of therapy, meaning how much live cancer is left versus how much is dead tumor. And the percentage of that appears to really correlate to prognosis and how patients will do. And so we get sort of an early marker, which I think can be really helpful for the patient, and the clinical team.
Yeah, it kind of logically kind of makes sense, because you had the tumor burden and you give immunotherapy so that you basically have um, better the immune system is able to mount a better immune system to attack it because there's a large burden tumor present when you go through the immunotherapy, when you go through the neoadjuvant. In contrast, if you go through the adjuvant, you already remove the bulk of the tumor, then you give the immunotherapy, the immune system may not see as much of tumors, so sort of have that's one of the kind of benefit, the rationale we think why neoadjuvant is successful, basically. All right, we don't have that much time. We got 8 minutes left, but let's push a little bit further down and adjuvant for stage 2. I know this is even more controversy. And what is your stand on this? And how do you even advise patient about this?
Yeah, I find this to be really difficult because, while it is a discussion of risk and benefit, it is, it's a different magnitude.
Sure.
And you're still talking about drugs because right now we have just immunotherapies that have shown benefit. We're still talking about drugs that carry about a 10 to 15% risk of severe side effects, some of which may be permanent, particularly things that affect the endocrine system, like the thyroid. You mentioned type 1 diabetes. That is a life-altering diagnosis, while rare. So we have that discussion. Again, I think it depends on the patient. It depends on how high risk the stage 2 is. Again, these are thick primaries, but node negative. And I will say in my experience, many patients opt for just close observation. But we do offer it, for select patients who are interested.
So at least you have that discussion with them.
We do. Our
Okay.
surgeons, are very much involved in this process, and they do usually refer, patients to us for at least a discussion.
Yeah, I think that's valid. That's very, very valid. So we covered a lot, right? We covered immunotherapy. We went down target therapy, stage 4, all the way to stage 2, and adjuvant, neoadjuvant. Maybe you can just touch a little bit about what clinical trial is like. I know this is another big part of your day-to-day activity. And maybe you can dispel some myth for our patients and the public.
Yeah, I think clinical trials and clinical research is part of why we have the drugs we have today. And that takes a lot of trust on the part of the patients and their families, and it really is a partnership. A lot of trials today focus on trying to come up with different combinations to overcome resistance to immune therapy and targeted therapies. I would say a lot of our focus is on immune therapy. I think one of the biggest myths, is the concept of like a placebo.
Sure.
Like sugar pill. And I would just say, for patients with stage 4 melanoma, that's just really not something that's done anymore. I think on the flip side, the other thing, despite a lot of promise, sometimes there's a ton of promise. We may have even like early stage results from earlier, smaller trials. I'm always really careful to say, if we knew it was better, we wouldn't need to do the clinical trial. So there is some risk there. Clinical trials usually, require a bit more of a rigid schedule. They're sometimes not offered, widely. So they require more support and logistics on the part of the patient. And it's a real barrier and something, we're all working to overcome that, the majority, not just in melanoma, but the majority of adult cancer patients are not treated on clinical trials. And so, would love, to think about ways to continue to partner with our patients in the community and broadening that access.
No, I think you touched upon two very important areas. One is access, right? And then second is there is a kind of a logistic challenge and the demand that put on a patient who is already maybe ill and have to come into the center.
Absolutely.
And getting blood done, getting imaging. And lastly, I think you said something very interesting. very poignant, very like sort of accurate. That is managing the expectation, because a lot of a patient is sort of so concerned. They sort of so much hope hinged upon that miracle drug in a sense. Really have to manage that. Okay. First of all, thank you so much. And what last words advice you have for your patient that, either give them hope, inspire them? And what do you tell your patient? What do you tell the people who's watching this video who have, let's say, advanced stage melanoma?
Yeah, no, again, thanks for inviting me, and just to be able to share my perspective. It's such a challenging disease, but there is really more hope than ever before. It is such a privilege, to see patients who come see me year after year, now for many years, some of whom were on some of the original, clinical trials, and that's the hope that really keeps us going. And I think finding a team, finding an oncologist that you can trust, I think is, so important. And I think, seeking different opinions too, right?
Sure.
Is I welcome that. If my patients, seek additional opinions, and don't be afraid, to advocate for yourself. But, it's a tough disease, and having, that support team there is so key.
Well, April, I can't thank you enough for taking your time. I know how busy you are and everything, and really, really appreciate your time and all the really, really insightful comment and advice for everyone. Thank you.
I appreciate it. Thanks again for having me.
Bye-bye.
Bye.